The woman who can afford and the woman who cannot afford should still have the same access to care. And that's not the case in this country.
This is the Dr. Tlaleng Cooking Show. Thank you very much for being here.
I'm Dr. Tlaleng Mofokeng, and I am an abortion provider. And today we bring you a very important topic on abortion rights and abortion access. Let's dig into this very important conversation, one that you know is very close to my heart. Join me and my guests as we dig deeper. I'm so honored today to introduce to you two guests around this table that are called colleagues, but also that I personally look up to. We have first our Ndu, who is a researcher and activist of note, and we also have Khanyisa, who's a lawyer, who's also been supportive in terms of how she works at the intersection of law and medicine. And to start off with, Khanyisa, you are the lawyer. Would you say there's such a thing as an illegal abortion in the first place?
So there's definitely nothing like an illegal abortion. There's either a safe or unsafe abortion. The law, in terms of what it prohibits, is the provision of an unsafe abortion. So that is the provision by someone who's not licensed to provide an abortion or who's not qualified to provide an abortion. But in terms of the person seeking the abortion, there is no limitation in terms of where they can seek it or how they can seek it. It's always on the provider side, what makes it a safe or unsafe abortion.
In your experiences, Ndu, now that you've become a trainer of other people, what has been some of the challenges in the context of South Africa, despite the law, to provide safe abortions?
The guidelines are very straightforward on who can and cannot provide, and WHO has also given us a definition of who can and cannot provide abortion services. Very clearly, someone who has been trained to provide the services. Someone who has not been trained is regarded to be providing an unsafe service. And the challenge is, in this country, we see that going on all over the country, that people who have not been trained are actually providing the service, which is something which the Department of Health seems to be turning a blind eye on, and which still continues to put lives of people who require the service at risk. Every day in this country, you drive around and see posters of safe abortion in all the cities and towns in this country, and clearly that should not be happening, but it continues to happen. And I think what is important is the reason why abortion had to be legal in the country. The data around the world tells us why abortion is such a crucial issue and has to be, at least at a minimum, be allowed by countries to be legal, because it leads to reduction of maternal mortality or the number of women, girls, and other people who become pregnant. It reduces the number of people who become pregnant who die because they were pregnant. And the data tells us that that is the case. So it is the state's responsibility to make sure that those services are safe, available, are of quality, are respectable.
And I think this is an important one, because on the one hand, you've got the law that says, yes, you are absolutely having a right to have this medical procedure. And on the one hand, you have untrained providers who even pretend to be doctors, right? Completely doing the wrong thing with impunity. But you also have another level of stigma where people have information perhaps. And stigma, I don't know if it's something that providers themselves as healthcare workers, like rona ba ileng ko sekolong to be nurses and doctors, we also have stigma. But people who need abortions, le bona self, have stigma. So how do we deal with this issue, ya stigma?
Yeah, so that is definitely an issue, and it's one of the biggest issues that we have to grapple with, stigma, because it's the woman who is seeking the abortion, or the person who's seeking the abortion, who is faced with stigma, whether it's at home, whether it's personal stigma that they face about the decision they have to make, and so they grapple with that issue, and so you often find women delaying that process because of this internal debate that they have with themselves about this decision, not whether or not it's the right decision in terms of their socioeconomic circumstances, their mental health, or the like, but in terms of, grappling with the stigma of it all, whether it is cultural, religious, whatever it is that's preventing them from making that decision that's right for them. And we've had a number of those cases, and oftentimes the saddest part is that it's the young people. So it's the young girls under even the consenting age that have that consenting age for sex, carry that stigma heavily. And so they come to us quite late to seek these help in a desperate attempt to try and help themselves.
One study that was actually done to look at the stigma level at the facility showed that the facility managers are actually one barrier that leads to healthcare providers not actually providing services because of being stigmatized when they actually provide the service, and they finally decide that I'm not going to provide a service if I don't get supported. And finally the facility then decides if that one provider does not get support, they also decide they are not going to provide the service. So it gives you a picture, once you are at that level where you actually provide the training, that there actually are providers who are willing to provide the service, but the support, they don't actually get support at facility level, from CEO level to district managers, district directors, but also security staff at the gate, the cleaners, the pharmacists who are themselves who order drugs.
And maybe that speaks to the reasons how they get pregnant, right? Because we live in a country with very high rape statistics and experiences. And so on the one hand, we talk about, abortions being unsafe and maybe not being accessible. But we also have to talk about other services around sexual and reproductive health that are also lacking. Like if you do get raped and you want emergency contraception, or you need some sort of support after, you are still not guaranteed that, right? So take us through some of the kinds of people who require abortions, because there's this idea that an abortion is just something for young girls who are just reckless, which is also not true.
Well, I often say I am yet to meet a person who finds making that decision a very nice decision, finds it very easy that, I'll just go and have an abortion because it's such a nice procedure, because it's never an easy decision for any person to make. And I think there's always that assumption for people who speak against the procedure because they don't know the decisions that goes into finally having to make that decision, what goes on in the mind of a person who has to make that decision. I think that is why it's also regarded, you will know as the UN Special Rapporteur, that it may also be regarded to be as torture. There's just so many situations where someone is actually sometimes forced to continue with a pregnancy they do not want because of the circumstances. She's lost her job. There are issues around financial stability, issues around the relationships they are in, and the partner is saying, if you continue with this pregnancy, then I'm out of it, I'm out. And she wants a pregnancy, the partner doesn't want it. So there's a lot of reasons why a woman would make a decision, and it's never an easy decision.
And should we be judging women or giving them any different care?
Not at
simply
all.
Because of the reason?
Not at all. And as people normally would like to say, women use abortion as a method of contraception, that there is no evidence that that is the case. Can we just respect that decision that an individual has made and make access possible for any individual who makes that decision?
And I suppose which is why a lot of the advocacy is around safe abortion access, right? Because we know that in some instances you may need more than one abortion, right? And when the procedure is done safely, you can actually be okay and be supported both mentally, emotionally, but also physically.
Yeah.
Just to add on to what Ndu was saying, that our cases primarily stem from the issues that we see that relate to abortion. So, for example, scarcity in resources in the state, because there's not enough abortion facilities that provide these services. There's not nearly enough abortion providers. So there's not enough service providers within those facilities that provide. And then, of course, stigma, right? So a lot of the women that come to us will come because they've been denied abortions in their local health facility. In terms of the law, a first trimester abortion will happen from the 0 to 12 weeks, and then a second trimester from 12 weeks onwards. Below 12 weeks, you don't need a reason. So you can go to your local clinic and request an abortion. It's a medical procedure. They're meant to give you some pills, and you do part of the procedure at home. And then the rest of it, or from the second trimester, you do it in a facility. So that would be a surgical abortion, or even a longer medical abortion. So a number of the cases that we've seen would be women in that second trimester because they've denied, not because they haven't gone to the facility, but because they've been denied their whole first trimester, seeking various facilities where they can get this procedure. And that process will be delayed until they're in the 18th week, 19th week. Then they're faced with even more stigma because people are saying, oh no, or at least the healthcare professionals who have that stigma will say things like, it's too close to the edge, it's too close to the limit, or the fetus is showing these symptoms or whatever it is, and they will deny on that basis. Or even with the younger generation, they'll deny on the basis that you need parental consent, which is not in the law, by the way. It is completely a woman's choice to have an abortion. She does not need any consent from anyone. And so in the second trimester, the law provides that it's limited to 5 reasons that you can get an abortion. So, and they're quite wide-ranging reasons, right? So it could be your socioeconomic circumstance, it could be your mental health, it could be the fact that you were raped, or that the pregnancy was a result of incest. It could be because the fetus is showing some sort of deformity, or that the pregnancy is a danger to your health as the woman who's carrying the pregnancy, or the person who's carrying the pregnancy. And so the issues that come along are those type of issues. A couple of weeks ago, I actually had a case in the Eastern Cape with a young girl who was 16 years old at the time of approaching us, and she was in her 20th week. So when we fought for her to get the scan at the facility, even getting the scan was a fight. They in fact told her that abortions end at 18 weeks.
But it's misinformation.
Misinformation, and it's abuse of medical knowledge, because you're taking advantage of the person who doesn't know. Luckily, we were there with her. How it started, and if I may go a little bit back, she is from Queenstown, and in that area there are no abortion second trimester abortion providers. There's no designated facilities to provide. She had to travel about 3 hours away to East London, find money somehow. As a 16-year-old who doesn't have any financial resources, find money somehow to travel to East London, where she met up with our field researcher there, and we then started assisting her. We had to then fight for her to get that service. She was booked, her file was opened, the process was nearly done. She was set to get her abortion the next day. The day that she went to the facility the next day, nobody was there. The nursing staff essentially went on strike. They didn't come to the hospital because they were refusing to provide this one little girl with an
Okay, but now what are the consequences? How do we manage that? Because that's clear medical malpractice.
Well, we've decided that we're going to lay complaints against the necessary professional councils, as well as the HPCSA and the health ombudsman, against these nurses for this conduct. That girl was then had to then be transferred to another hospital where she was going to receive care there. She faced even more trauma there because the nurses and the doctors refused to help her. They essentially gave her the medication and said, "You do it yourself," which is something we see quite often. And she had to administer the medication herself. Nobody knew that she was bleeding too much. She had needed a blood transfusion. She had an infection that was developing into sepsis, at a healthcare facility.
And all of those because of the lack of adherence to protocol, because it doesn't have to be this way, right? Do women in private face the same level of obstacles that we've just heard about?
Well, they probably don't because they can afford to pay, which brings the question of inequality and equity in health in this country. And the woman that Khanyisa has just referred to in that area of Eastern Cape, the woman in Sandton, should have the same access to care. The woman who can afford and the woman who cannot afford should still have the same access to care. And that's not the case in this country. The poor, marginalized, and vulnerable women continue to face the situation that Khanyisa has just described now, which is actually a very sad situation in most rural areas of this, even in the urban areas actually of this country.
And you do training of healthcare workers and providers. What needs to change in terms of the mindset and the clinicians? Because we need more.
There's what we call a whole facility kind of intervention that focuses on everyone who works at that facility, that they should understand what the Choice on Termination of Pregnancy Act actually is about, what the Constitution says about reproductive health. Because after doing all these interventions, sometimes you do understand that some people really did not have any idea that being a barrier can actually cost you a life in jail.
And it's a human rights issue.
It's a human rights issue, yeah.
And talking about human rights, dignity is really important. So what does a dignified care look like in abortion?
In abortion, there's what we call a triple AQ. Abortion services should be available. They should be available, affordable, acceptable. A provider who provides the services should make sure that they offer a dignified service. And if a woman who goes to a private provider to get a service is treated well, in the public sector, they have the Batubile principles, which are stuck on the wall in all the facilities. But when you go and ask them what do the Batubile principles say about people's dignity and how they should be treated, they probably last read them when they were put on the wall, and they really don't take note of them. But they all talk about how respectable the care should be that is provided to everyone, every patient who comes to a facility, despite the fact that they have come there for an abortion. How different is abortion than someone who has come for a diabetes medication or for TB or for HIV medication? That care should still be it should still be a dignified and respectable care.
When a woman approaches a facility, she's entitled in terms of the law to pre and post-abortion counseling. And what that counseling looks like is quite important to the decision that she's going to make. There seems to be quite a misunderstanding, at least with abortion providers in the state, about what constitutes pre-abortion counseling. Often we find that the conversation is quite it pushes the woman or the person seeking the abortion towards not seeking that service. Something that we came across in our field research in the Eastern Cape was some facilities that would allow religious organizations to step in and do the pre-abortion counseling. Obviously, that is not standard or proper procedure, and it's also not standard and proper abortion pre-abortion counseling. Often these women are promised, we will take care of you, we will take care of your child. Don't make this decision, and on the basis of that promise, they turn away from making the decision, and they're not left to their own devices once they have the baby. And then also in terms of the first trimester abortion, explaining the process and then providing the care in terms of how the guidelines say that you not want to provide the care. And then in terms of second trimester abortion, also providing the care in the way that the law requires you to. So what that looks like would be not requiring a 16-year-old to administer their own abortion drugs. It would be to make sure that the patient is comfortable, is aware of what's happening, can talk freely about what is happening. Often we find that women who are seeking abortion at public health facilities would be placed in the labor ward, for example, where there are new and doting mothers and babies and all of that, in a way to try and coerce them into not having the procedure, or to make them feel bad about the decision that they've done. We say that is abusive behavior. It is abusive medical behavior, and it's simply not acceptable. There's a pre-decision abortion counseling, then there's a post-decision. So those look different. So the one is where a woman's trying to get information about what the procedure should look like. And then the other is when she hasn't yet decided and might need a listening ear to weigh her options. In none of those cases is an abortion provider or the counselor who's giving her some counseling meant to impose their own views on what should be done. And so what it would typically look like is, for instance, if I've made the decision and I come to you, Dr. T, and I say, Dr. T, I want to have this abortion. I've made my decision. I've looked at my circumstances. I really cannot. What it's meant to look like from your end is, okay, I hear that. What are your questions about the procedure going forward? It's clear, very simple. And then we can talk about, how long am I going to bleed for? Will it be painful? Will I get pain medication to assist me? How long is the procedure once I've left the facility? Things like that. Should I come back for cleaning or, post abortion provision or post-abortion services? What does that look like? Absolutely. If I haven't made the decision, it looks quite different.
Ndu, what does dignified care look like?
It should be non-mandatory and non-directive. So if a client, because we prefer to call them client because they are not sick, So if she has come in as they already made their decision, there is no reason why you should still help on to insist that I must still counsel you, but you have already made up your mind that you want to go ahead with the procedure. All that needs to happen is for me to explain what the procedure will be like. This is how far you are, and these are the methods that are available, and this is what you'll feel when we do this method. This is how many pills you are going to take, and this is how long the bleeding will take, and these are the danger signs. If there are any complications, this is what you'll see, and this is what you should do if you should come back when you should come back if there's any reason for you to come back. So that's the information that should actually be given to all clients who actually are requesting an abortion. So it's non-mandatory and non-directive. So a woman is not directed, or a person is not directed in any way. It's them to make a decision. If after explaining everything they haven't made up their mind, then you can ask them to go home and still think about it. If they still want to go, okay, let me go talk to my mom, or I have a supportive partner, I still want to go and discuss this with them. Go ahead and do that. And when you've made up your mind, come back and let's take the discussion forward. That's how it should happen.
On a more personal note, why do you do this work of advocating for safe abortions?
Dr. T, to be honest, it's because I'm a woman. It's because I understand the realities of living in this country. It's because I understand the realities of access to healthcare for women, even from contraceptive care, before we even start talking about abortion. At Section 27, we do work on contraceptives or stockouts of contraceptives, and what we found is that in some districts across the country you can have up to 80% of the available contraceptive methods not available to the women in that area, and some of our clients actually don't even know what contraceptives are, so they even get failed at the education level when we look at sexual rights education at school. And so if you look at that and you're a young and you're a black woman and or black person coming through the system, you failed at high school or school level, you failed at healthcare facility level in terms of provision of healthcare services or prevention of pregnancy services, and then you failed at getting the first trimester abortion, and then you failed at getting the second trimester abortion. And a lot of the time it happens to the people that, like Ndu was saying earlier, it happens to the people who are so in such dire socioeconomic circumstances that they actually cannot afford to have yet another child, that they're actually too young to have a child, and having that child will damn them to the poverty that they already grew up in or already found themselves in. And so that is why I do that. I do the work that I do, because I understand the walk through life that these women have to face, and having these challenges at every turn is actually quite unfair.
How's Ndu? Why do you keep doing this work?
Oh my goodness, darling, it maybe I will start my response in how I became interested in this work, and that will be before abortion even became legal in this country. Because when I trained, abortion was not legal, and I remember that stuck in my mind, the days when the gynae department, I trained in a hospital that was really new. It was a very new hospital, but I recall to this day that gynae department, the smell in that ward. And I didn't know at that time the state of unsafe abortions that were happening in this country. And I didn't know the legal and illegality of abortion during those years. And then I kept asking, but why is this ward so smelly? So it's only during my training days that I understood why. So those women were lying in bed, some were dying, some had an opportunity to be taken to theater and to survive, some were losing their wombs in the process. And I knew then that that's the work I'm going to do. And so I kept track of the abortion process when, after 1994, and after abortion became legal in 1996, and I knew that this is the work that I will be doing years later, after I came back from England, where I already did this work. So it's work I've been doing for many, many years, and I probably will die being an abortion
And we are
provider.
grateful
Absolutely.
for abortion providers
Absolutely.
always,
Yeah.
both clinical and legal.
Yeah.
And as it is tradition with the show, we always want to wrap up with a moment where you raise your glass to something important to you that we can toast to. So we'll take that moment now to do that as we wrap up, so that we talk about our abortions, we shout them out, because there's nothing to be ashamed of for seeking healthcare. So for you, Khanyisa.
I'd like to raise my glass to access to healthcare, equitable access to healthcare for all women in this country, all people capable of falling pregnant in this country, irrespective of their socioeconomic circumstance.
I'm raising my glass to reduction to abortion stigma, and I really want us to see us reducing deaths due to unsafe abortion, and reduction in maternal mortality due to that.
Cheers to that. And thank you to you both for joining me, both as clinical provider and legal provider. So thank you for joining us, and I hope that this conversation has given you insightful info on how to seek an abortion, when to seek an abortion, and that you understand that fundamentally it is your right to make decisions about the kind of healthcare that you need, and that indeed abortion is healthcare, and that you deserve dignified care in you seeking that abortion. Please continue to like and subscribe and leave your comments, and importantly, share this conversation with as many people as you can. Thank you very much for joining us on the Dr. Tlale Mofokeng Show. Till next time. Okay, we're drinking again.